In this tutorial, we'll review sudden cardiac death associated with mitral valve prolapse and mitral annular disjunction. We'll start by reviewing two cases of women who were found to have bileaflet mitral valve prolapse and associated mitral annular disjunction, one who was referred to her cardiologist simply due to palpitations, and the other who presented after an out-of-hospital cardiac arrest. We'll then try to identify signals in these cases that may be predictive of malignant arrhythmias and review what can be done to mitigate that risk. The first case is that of a 53-year-old woman who was referred to a cardiologist due to palpitations. While reviewing her past medical history, her cardiologist learns that she has had prior episodes of syncope with prodrome. A transthoracic echocardiogram was ordered, which revealed bileaflet mitral valve prolapse and mild mitral regurgitation. A 30-day Holter revealed a PVC burden of 7% with 2 short runs of NSVT. A cardiac MRI was subsequently ordered, which revealed focal basolateral late gadolinium enhancement as well as mitral annular disjunction. The second case is that of a 36-year-old woman who presented to the hospital as a witnessed out-of-hospital cardiac arrest while eating dinner at a restaurant with her husband. The initial rhythm reported by EMS was ventricular fibrillation, for which she received 5 shocks before achieving ROSC. ECG on arrival to the hospital revealed normal sinus rhythm with a normal QTC. Left heart catheterization revealed clean coronaries, and transthoracic echocardiogram revealed bileaflet mitral valve prolapse and trace mitral regurgitation. A subsequent cardiac MRI revealed focal basolateral late gadolinium enhancement and mitral annular disjunction. Prior to discharge, the patient received a subcutaneous ICD for secondary prevention. But the challenge becomes trying to determine the likelihood that our first patient develops a life-threatening ventricular arrhythmia like our second patient, and then trying to develop a thoughtful approach for risk mitigation. During this tutorial, we'll review the anatomy of the mitral valve and its annulus and see how appreciating its shape, a hyperbolic paraboloid, can help us better understand pathological processes. We will then review the incidence of sudden cardiac death in patients with mitral valve prolapse and see that it is believed to account for as many as 29,000 deaths annually in the United States, a number even higher than that attributed to sudden deaths due to hypertrophic cardiomyopathy. Next, we will review signals that can be elicited from imaging studies that can be used to risk stratify individuals who may be more prone to developing malignant arrhythmias. And finally, we'll review the most up-to-date algorithms for approaching high-risk patients with mitral valve prolapse and mitral annular disjunction and explore the utility of ICDs, mitral valve surgery, and ablation as a means of primary prevention. We'll start by taking a look at the mitral valve. Here we can see it from a surgeon's view. If we tilt the heart backwards, we can see the mitral valve annulus has several curves. As we continue to rotate the heart, we see that the annulus curves across 2 planes and bears a shape similar to that of a well-known stackable potato chip, which, mathematically, is known as a hyperbolic paraboloid. And just like the Pringle, the mitral annulus curves along the anterior-posterior plane, as well as the anterolateral posterior-medial plane. Looking at it from above, we can once again see it from a surgeon's view. But further complicating its geometry, but explaining the naming convention of its landmarks, is the fact that it's situated in the heart at an angle when viewed from the coronal plane. Here we see that the posterior medial commissure is more medial than that of the anterolateral commissure. Interestingly, hyperbolic paraboloids can be found in other facets of nature and are believed to be integral in allowing the mantis shrimp to pack a deadly punch. The mantis shrimp, seen here punching a crab, can deliver a punch with the same force as a .22 caliber gun, despite its small size. But producing such a high-speed punch wouldn't be possible by muscles alone. But the somatopod leverages the mechanical design of the saddle-shaped joint to store a great amount of potential energy before releasing it as kinetic energy. The mechanism is illustrated nicely in this animation from the YouTube channel Smarter Every Day. And just like the joint of the mantis shrimp, the mitral annulus compresses along the AP axis during systole and expands during diastole. Importantly, in pathologic states, such as mitral valve prolapse, particularly with significant annular disjunction, the annulus paradoxically expands during early systole rather than compressing. Mitral valve prolapse is defined by mitral valve displacement more than 2 millimeters above the mitral annulus in the long axis view. If it's less than 2 millimeters and the coaptation point is below the annulus, it's considered billowing. And if the undersurface of the mitral leaflet tips, flip up into the atrium, it's considered flail. Mitral annular disjunction is characterized by the atrial displacement of the hinge point of the mitral valve annulus from the ventricular myocardium, and can occur either in conjunction with bileaflet mitral valve prolapse or independently. And finally, there's a phenomenon of pseudomad, which is characterized by the illusion of annular disjunction which may occur when the posterior mitral leaflet abuts the left atrial wall during systole. And although mitral annular disjunction was first described by the late Johns Hopkins pathologist Grover Hutchins in 1986, rigorous research into its arrhythmic potential didn't take off until the 2010s. But as mentioned earlier, during normal physiological circumstances, the mitral annulus expands during diastole and compresses during systole. When mitral annular disjunction is present, the annulus might look normal during diastole, but it expands during systole. On the left, we see two movies from cardiac MRIs, for which the speed has been slowed down to 40% to more easily track movement during systole and diastole. The leftmost movie is from a normal heart without mitral annular disjunction, and we can see the mitral annulus compresses during systole and expands during diastole. The movie on the right is from a patient with mitral annular disjunction, and we can see that during systole, the annulus expands as the basolateral myocardium appears to thicken. This motion has been described as systolic curling. During this expansion, the lateral annulus moves apically at an accelerated rate, producing high tension at the insertion site of the basolateral myocardium. This can be visualized on tissue Doppler of the lateral annulus in the form of a high-speed spiked-appearing systolic waveform, which has been termed the Pickelhaube sign due to its resemblance of the spike on these German war helmets. These increased traction forces on the myocardium have been found to cause inflammation and activate fibroblasts, thus promoting fibrosis and scar formation. And during states of increased adrenergic tone, this can promote PVCs believed to be triggered by stretch-induced delayed after depolarizations, and can also trigger ventricular tachycardia and fibrillation. But now that we've examined how the proposed mechanism for how mitral valve prolapse and annular disjunction can create a substrate for ventricular arrhythmia, we'll next take a look at how likely we are to encounter this in our clinical practice. Mitral valve prolapse can be expected to be found in about 2 to 3% of the general population, affecting about 10 million Americans and 240 people worldwide. It's important to recognize, however, that prior to 1987, mitral valve prolapse was grossly overdiagnosed, being reported in up to 1 in 6 echocardiograms. This was prior to the appreciation for how the saddle shape of the annulus can affect the appearance of valve height in different echocardiographic planes, with the 4-chamber view particularly contributing to overdiagnosis of prolapse. But in 1987, Drs. Robert Levine, seen here on the left, and Dr. Arthur Wayman, seen here to his right, highlighted the effect that the saddle shape of the mitral annulus has on mitral valve imaging. In the figure on the left, they draw attention to the fact that the apical 4-chamber view intersects the mitral annulus across its highest points, eliminating overestimation of mitral valve prolapse. But when the beam is tilted as in the apical four-chamber view, it intersects the annulus across lower points, creating an illusion that the mitral valve is prolapsing. They then did an experiment where they rotated an ultrasound beam 360 degrees around the mitral annulus, and showed that when the beam was in the 0-degree position, it intersected the annulus at the lowest points of the saddle, but that when rotated 90 degrees, it intersected the annulus along the highest points of the saddle, and that this pattern repeated as they continued to spin the ultrasound beam. Now looking at the heart through the barrel of the left ventricle, we can see what happens when an ultrasound beam intersects the heart in the apical four-chamber view. We can see that the beam intersects the annulus, not at the lowest point or the highest point, but somewhere in between, just as depicted in the initial diagram by Dr. Levine and Dr. Wieman. Similarly, when the annulus is transected, as it is in the parasternal long axis view, the beam cuts through the annulus at its highest points. If the annulus is used as a reference point to define prolapse of the valves, we can see that when viewed in the parasternal axis, the valves do not rise beyond the Bloom beam, but that when viewed in the apical four-chamber view, the perceived lower height of the annulus creates the illusion that the valves are prolapsing above the entire annulus. But as mentioned earlier, modern estimates suggest that mitral valve prolapse can be found in about 1 in 30 individuals. Mitral annular disjunction, on the other hand, seems to have a much higher prevalence, which is dependent upon the imaging modality used to examine the mitral apparatus. Review of 1,400 consecutive echocardiograms in Japan revealed mitral annular disjunction in 9% of the population, with only 1% of studies revealing concomitant prolapse and disjunction. Review of 2,600 cardiac MRIs from the UK Biobank revealed annular disjunction in 75% of individuals, with about 3% having concomitant mitral valve prolapse and mitral annular disjunction. However, among patients with concomitant prolapse and disjunction, the prevalence of disjunction greater than 6 millimeters was less than 20%. Cardiac CT, having the highest imaging resolution, revealed annular disjunction in 96% of a cohort referred for cardiac CT in Japan, with the highest frequency of disjunction occurring in the anterior and inferior commistures, rarely being found in the inferior lateral wall. Finally, with respect to malignant mitral valve prolapse, or mitral valve prolapse believed to be the isolated cause of sudden cardiac death, an Italian registry of 650 consecutive cases of young individuals less than the age of 40 attributed mitral valve prolapse as the cause of 8% of cases, placing it neck and neck with hypertrophic cardiomyopathy and ARVC. A U.S. cohort of similarly aged individuals reviewed over a similar time period attributed mitral valve prolapse as the cause of sudden death in 4% of cases. A more recent cohort of 1,200 sudden cardiac death survivors at the Mayo Clinic revealed mitral valve prolapse as the trigger for arrest in about 1% of their population, 90% of whom were women. But to recap, about 20% of all 3 million yearly deaths in the United States are attributed to heart disease, with about 50% of those being due to sudden cardiac death, of whom about 4% in the U.S. are believed to be due to mitral valve prolapse, which, according to some literature, is similar to the number of sudden deaths attributed to hypertrophic cardiomyopathy. This 2020 JAMA article highlights that while the risk of sudden death due to hypertrophic cardiomyopathy is more than twice that of mitral valve prolapse, due to the higher prevalence of mitral valve prolapse compared to hypertrophic cardiomyopathy, the total number of deaths attributed to mitral valve prolapse is actually greater. So, is there a way to spot the proverbial Waldo who will account for 1 in 250 deaths this year, within the sea of 1 in 750 patients with mitral valve prolapse presenting to your clinic? The answer is, it's challenging, But next we'll take a look at techniques for risk stratification. In recent years, several signals have emerged which appear to increase the risk that an individual with mitral valve prolapse will develop malignant ventricular arrhythmias. Among them are many imaging findings, including bileaflet prolapse, which has been found to be over twice as prevalent compared to single leaflet prolapse among patients who developed sudden cardiac death attributed to mitral valve prolapse. This finding seems to be consistent across the globe, as this study of an Italian cohort of patients who suffered sudden cardiac death also found bileaflet prolapse in 70% of individuals whose death was attributed to mitral valve prolapse, which is similar to the 78% of bileaflet prolapse found in a Canadian cohort of malignant mitral arrhythmias. With respect to mitral regurgitation severity, while greater severity is associated with greater mortality over a 10-year period, the majority of patients determined to have mitral valve prolapse-related sudden cardiac death actually seem to have less than severe mitral regurgitation, with 65% having only trivial or mild regurgitation. Several studies have implicated mitral annular disjunction as a risk enhancer. Dr. Serrano's group at the Mayo Clinic examined a cohort of 600 patients with mitral valve prolapse over a 10-year period and found that of those that went on to develop ventricular arrhythmias, 44% had mitral annular disjunction. Similarly, about 50% of those with mitral annular disjunction went on to develop an arrhythmic event defined as VT or VF within 10 years, compared to 30% of those without mitral annular disjunction. It's important to note, however, that despite the increased risk for arrhythmic events, overall 10-year survival for this cohort of patients with mitral valve prolapse and concomitant mitral annular disjunction was very good, at 97%, and even higher than that of their non-MAD counterparts. As mentioned earlier, the increased traction forces produced by mitral valve prolapse and MAD are believed to induce myocardial fibrosis and scar. In this study of roughly 500 patients with mitral valve prolapse, the presence of late gadolinium enhancement in the left ventricular wall was associated with a 5-fold increased risk of ventricular tachycardia greater than 30 seconds or aborted sudden cardiac death with ventricular fibrillation, compared to those who had no left ventricular LGE. As mentioned earlier, you don't necessarily need a cardiac MRI to find evidence of high lateral traction forces caused by mitral valve prolapse and disjunction. The Pickelhaub sign, characterized by a high-velocity systolic lateral tissue Doppler signal, was found to be 3 times more common in patients with mitral valve prolapse who went on to develop malignant arrhythmias. Similarly, the double peak pattern, which may be seen on strain imaging in patients with mitral valve prolapse, is thought to reflect the effects of elevated traction forces during late systole and has been associated with increased risk for malignant arrhythmias. As a reminder, longitudinal strain looks at the distance between speckles in the myocardium to determine the extent of ventricular contraction in the longitudinal plane. Under normal circumstances, the strain becomes more negative during systole and less negative during diastole. During early systole, the strain pattern in mitral valve prolapse may look normal. But by mid to late systole, as the ventricular myocardium experiences opposing forces from the elevated traction on the cords, the strain signal becomes less negative. Then, during early diastole, when the tension is released, the strain signal briefly becomes more negative again, creating a double peak pattern, as demonstrated here in this paper by Dr. Nagata. This pattern, when present in patients with mitral valve prolapse, has been associated with a greater than 3-fold increased risk for developing ventricular arrhythmias. But echo and MRI aren't the only tools that can be used to risk stratify patients for malignant arrhythmias. ECG and Holter data also seem to share some signals as well. In this small cohort of 43 patients whose sudden death was attributed to mitral valve prolapse, 83% were noted to have inferior T-wave inversions on a recent 12-lead ECG, which has been hypothesized to occur due to repolarization abnormalities from increased stretch on the myocardium. When it comes to Holter monitoring, findings of complex ventricular ectopy have also been associated with high mortality rates. In a cohort of 600 individuals with mitral valve prolapse, those with faster VT, specifically greater than 180 beats per minute, had a 25% mortality rate at 8 years, compared to 10% for those with trivial or no ventricular ectopy. Fortunately, those with severe ventricular arrhythmias accounted for the minority of the cohort, with greater than 50% having only trivial ectopy. While the authors of this study included examples of what mild, moderate, and severe ventricular arrhythmias might look like, it's important to recognize that complex ectopy is not always about speed. Less frequent but short-coupled PVCs have also been implicated as risk enhancers in patients with mitral valve prolapse. And here we see that when the PVC falls just a bit too early, it initiates a run of polymorphic VT. And when PVCs occur in patients with mitral valve prolapse, they most commonly arise from the posterior papillary muscle, followed by the right ventricular outflow tract. And finally, there may be some risk signals in the clinical history and baseline demographics. In a cohort of 42 patients who received ICDs as secondary prevention after sudden cardiac death attributed to mitral valve prolapse, 95% were found to have symptoms of presyncope preceding the arrest, and 60% had syncopal episodes. And while several small studies with fewer than 50 patients have suggested that malignant arrhythmias occur with a greater frequency in women compared to men, larger studies with cohorts in the hundreds to thousands have found that the sudden death due to mitral valve prolapse is more evenly split between the sexes. Now, with some of the risk modifiers in mind, let's take a look at some of the proposed algorithms for mitigating these risks. Several algorithms have been proposed in recent years, including this one from a 2022 consensus statement on arrhythmic mitral valve prolapse from the European Heart Rhythm Association, and this 2023 update from a review paper by Dr. Serrano at the Mayo Clinic, as well as this 2024 update in JACC. All algorithms start with the clinical history and agree that if a patient survives sudden cardiac death, they should get an ICD. They also all agree that whether a patient with mitral valve prolapse is asymptomatic, minimally symptomatic, with symptoms of palpitations, presyncope, or syncope, or a survivor of sudden death, they should all undergo additional cardiac imaging for further risk stratification. And as we saw earlier, the most helpful studies are echocardiography with strain and cardiac MRI. They also all agree that all asymptomatic and symptomatic patients should undergo Holter monitoring, and that the number and severity of high-risk features acquired by cardiac imaging should guide the frequency of Holter monitoring follow-up. For those with only a few high-risk features, less frequent Holter monitoring may be warranted, but for those with several high-risk features, a Holter every 6 months to a year or implanting an ILR may be reasonable. And finally, for those who are found to have complex PVCs or ventricular arrhythmias, they propose consideration of prophylactic ICD or surgical repair if there's an indication based on the severity of mitral regurgitation, and that if there are frequent appropriate ICD therapies for malignant arrhythmias, to consider VT ablation and initiation of antiarrhythmics. While prophylactic ICD implantation has not been endorsed in any formal guidelines, it is being trialed at institutions with dedicated mitral valve centers. Dr. Mark Miller at Mount Sinai describes the case of a 55-year-old woman who was referred to their center due to palpitations, who had imaging findings of bileaflet mitral valve prolapse, MAD, and focal late gadolinium enhancement. Due to the finding of complex, short-coupled, and pleomorphic PVCs with NSVT on Holter monitoring, decision was made to implant an ICD. And 1 month after ICD implantation, the patient received an appropriate shock for ventricular fibrillation, which had been initiated by PVCs. Despite introduction of beta blockers and flecainide, the patient continued to receive appropriate ICD shocks for VT and VF, so decision was made for the patient to undergo papillary muscle VT ablation. Here we can see that this was a patient who presented with palpitations, was found with high-risk PVCs and NSVT on Holter monitoring, for which a prophylactic ICD was implanted. But zooming in on this algorithm, we can see that one of the considerations is mitral valve repair. So let's briefly review some of the data looking at mitral valve surgery to reduce ventricular arrhythmia. Unfortunately, there is limited prospective data, which currently suggests little improvement in PVC burden. In this study of 32 patients from the Mayo Clinic who were referred for mitral valve surgery due to mitral regurgitation secondary to bileaflet mitral valve prolapse, no significant change in PVC burden among the cohort was identified post-op. Interestingly, anecdotal data emerging from Mount Sinai, where they are integrating open-heart cryoablation with mitral valve repair, seems to suggest that this might be a viable strategy for a subgroup of patients. Here they report the case of a 35-year-old woman referred to their clinic due to palpitations who was found to have bileaflet mitral valve prolapse associated with moderate mitral regurgitation, mitral annular disjunction, and characteristic late gadolinium enhancement. Although her PVC burden was just 4%, she had short-coupled pleomorphic PVCs, as well as multiple runs of NSVT. She was initially offered an ablation for the papillary muscle VT, but after multiple recurrences, after 2 radiofrequency and cryoablations, she was referred for mitral valve repair. And 1.5 years post-op, her ILR reportedly reveals no evidence of PVCs or NSVT. Returning to our cases, we can now attempt to tally up their respective risk signals. Both patients have bileaflet mitral valve prolapse with associated mitral annular disjunction and only traced to mild mitral regurgitation. As we previously discussed, bileaflet prolapse is 6 times more common in patients who develop significant arrhythmias, and mitral annular disjunction is at least twice as prevalent. And notably, although the severity of mitral regurgitation is not impressive, we know that the majority of patients who go on to develop sudden cardiac death from mitral valve prolapse only have trivial to mild mitral regurgitation, like our patients. Here are representative cines from each of our patients. Here you can see the extent of the mitral annular disjunction during systole. And here is a frame from the lateral annulus tissue Doppler from our 53-year-old patient with palpitations. As you can see, it is just approaching the threshold of 16 centimeters per second, characteristic of the Pickelhaub sign, which we know is 3 times more common in patients who develop malignant arrhythmias. Each of our patients had characteristic late gadolinium enhancement along the basolateral wall, which we saw was 5 times as common in patients who developed malignant arrhythmias. Next, we can take a look at their respective baseline ECGs, which you'll note have T-wave inversions in the inferior leads, which, interestingly, was found in 83% of patients who had malignant arrhythmias. Holter data from our 53-year-old patient reveals short-coupled PVCs, and our 36-year-old patient has PVCs as well. And in both patients, the ectopy is pleomorphic with multiple morphologies, which we saw may confer a 2.5-fold increased risk of mortality. And finally, we know that both patients had prior histories of syncope and presyncope, which is found in 95% and 60% of patients who went on to develop malignant arrhythmias, respectively. And while current guidelines do not advocate for prophylactic ICDs, we saw that to mitigate the risk that our first patient succumbed to a malignant arrhythmia, she should continue to be monitored with at least yearly Holter monitoring, and possibly start a conversation about the risks and benefits of prophylactic ICDs. In summary, we saw that the risk of sudden cardiac death due to mitral valve prolapse, though rare, is not insignificant, and likely responsible for up to 29,000 deaths in the U.S. annually. We reviewed several risk modifiers and saw that a history of syncope or presyncope, complex PVCs, and evidence of increased traction on the left ventricle should prompt us to monitor for ventricular arrhythmias more closely, and consider starting a conversation about the risks and benefits of primary prevention ICDs, ablation, and mitral valve surgery.